tell us a little bit about how clinical equipoise really was a key factor in enrollment for the study and participation for study groups?
Yeah, absolutely. Maybe I can just give a very practical example. Working in the intensive care unit, and I'll use protein as an example before effort, for example. So working in the intensive care unit, I might be seeing patients one day, and the day that I'm seeing patients, I might say to our RD colleagues, hey, can we please provide 2 grams per kilogram per day to this group of patients that I'm caring for, mechanically ventilated patients who are going to need that intervention for, let's just say 2 days or more, right? I'm trying to identify those who are at high risk. And what's informing me of that recommendation is perhaps observational level data that seems to suggest, hey, if we provide those patients who have high nutritional risk more protein, there is an associated improvement in some clinical outcome. But my colleague might come on after me and say, you know what, for all the same patients, let's provide 1.2 grams per kilogram per day of protein. And what informs their decision for 1.2 grams might be another set of observational data that suggests 1.2 seems to be better because perhaps in that same data set, 2 grams were harmful. And so here we are, 2 clinicians, and I'm providing 2, my colleague might be providing 1.2, and both of us are informed by observational level data or small randomized control trial level data. And so then that goes into a guideline recommendation, and the guideline recommendation says, again, give us 1.2 to 2 grams per kilogram per day. And that's based on nothing more than observational level data. And both of those would be considered standards of care because that's what we're doing at the bedside. And it's not just me doing that perhaps at the bedside, but it's worldwide data that informs that's exactly what's happening at the bedside. So in other words, there's equipoise for these clinical decisions, and we don't have stronger data to narrow us to one side or the other. And when we have that, we can randomize patients to that intervention without changing any other aspect of their care. And so we do this in what are called pragmatic trials or comparative effectiveness trials, where we're comparing 2 existing standards of care.
Yeah, it's too bad we don't have a marker yet. Hopefully in the future we will have one, but I know that's a very complicated process to fully wrap our minds around. Otherwise we would have one at this point. So the autophagy aspect is certainly interesting. I think, we don't fully understand how protein versus calories versus the combination of the two, how that plays a role here. But I think that highlighting that difference in the individualization and not knowing where these patients lie, again, pragmatic study here, but indirect calorimetry was not used to kind of guide that. There's some suggestion that maybe using indirect calorimetry, we might be able to see some differences in how that ebb and flow of our energy requirements, and presumptively, our phases of illness may overlap here. Do you see that, or would you expect that a future study looking similarly at protein delivery differences using indirect calorimetry to guide those energy targets, do you expect that there may be any difference in outcomes? And if so, what would that look like?
I think that would certainly increase the precision of our prescription, because as critical illness ebbs and flows, well, then so are the resting energy expenditures. And so I think that is a tool to at least identify that. However, what I will say is that just because an individual's resting energy expenditure is up here, right? I don't know if it means that we need to replace all of this versus we need to replace this much, at that time. And perhaps the reason to replace this much is just to support the gut, perhaps enterally. And so I do think that it can increase the precision, help us, with this ebb and flow. But what I don't know if that translates into, well, this is how much you actually need to prevent a caloric debt or to try and achieve nitrogen balance.
And I think that that highlights two differences to me. Is one is we know that there's this endogenous energy production that comes along with critical illness and the acute inflammatory response, which certainly attempts or may meet a large portion of that patient's energy requirements without us delivering anything. But what it doesn't do is deliver protein. Hence the goal of delivering protein in these higher protein studies. Is it possible, though, that if we know this individual has higher energy expenditures, if we're targeting a higher protein during that time period, we might help prevent some of that muscle catabolism that may reduce those functional outcomes and eventual recovery for these patients? And then how does that overlap with these additional studies? So Nexus, EFFORT-X, and any additional ones that you might know of?
Yeah, absolutely. Up to this point, most of the data we have, whether it's energy or protein, is in the form of randomized controlled trials, is during that early acute phase. And arbitrarily, it's like the first 7 days of ICU admission, right? And of course, there's going to be patients who transition between the phases, even between those 7 days. There is recent data out of Australia, Leanne Chappell and her group. What they did was they gave critically ill patients during that early acute phase protein. They gave it to them enterally, and it was radio labeled. And what they found was that the protein is digested, the protein is absorbed. However, the protein compared to healthy volunteers was not used to make muscle. And so, in other words, the anabolic response is impaired during that early acute phase of critical illness. And when that anabolic switch turns on is unclear. But my hunch is that it's probably during the later acute phases, if not chronic phase of critical illness, when we're really talking about rehabilitation. And so this evidence is compelling because it tells us that what we're delivering is getting through, but it's just not used as a building block for muscle.
So I think that highlights to me that we don't know enough about every individualized patient's specific requirements. EFFORT found some differences in outcomes in certain subgroup populations. Can you tell us a little bit more about any future analyses that might be going on specifically with those AKI patients or those high SOFA scores? We know that you studied specifically patients at risk for or who may already have malnutrition, and how do those things overlap here?
Yeah, I think there's a few take-home points, particularly the manner in which we included patients. So, point number one: the reason that nutritionally high-risk patients were chosen was because there was observational level data that informed those patients had an associated improvement in clinical outcomes with a greater amount of protein. And those patients were identified using things like the modified Nutrix score, frailty score, and sarcopenia, assessments. And it turns out that those patients didn't have an improvement in outcomes with increased protein dose compared to lower. Now, if we look at all those patients and we try to find those subsets of patients who maybe did better or worse, well, those patients with acute kidney injury who were not receiving renal replacement therapy seem to have a signal of harm from greater amount of protein. And we're still trying to flesh that out, and that may be a secondary analysis that we will look at, because that can help inform future trials that enroll that subgroup of patients to say, hey, we may want to not, give these patients a large amount of protein. And this signal that was observed in EFFORT was replicated in 2 other trials. So the redox trial that gave glutamine found more harm with glutamine in those who had acute kidney injury. And then the NEPHRO-PROTECT trial, which was also conducted by Gordon Doig, a secondary analysis found that a higher amount of amino acids in those patients who had acute kidney injury was met with a signal of harm compared to those who got a lower dose of amino acids. So now we have 3 randomized controlled trials looking at subgroups of patients with acute kidney injury who seem to do worse with more protein. And again, for EFFORT at least, it was in those individuals who were not receiving renal replacement therapy. So that's the first subgroup. The second subgroup is sicker patients. And sicker patients, again, was defined by sequential organ failure assessment scores. For the audience, the SOFA score looks at 6 organ systems. It looks at how much vasopressor are you on, your circulatory system. What's your oxygen requirement, your respiratory system? What are your platelet counts, including, which is your bone marrow? What is your kidney level of degree of kidney injuries? Looks at your kidney function. It looks at your 2 other organ systems that I can't remember off the top of my head, but it puts it into a score. And the higher the score, the worse your predicted outcome is going to be. And it turns out that those who had a score of more than 9, which are fairly sick patients, pushing more protein in those individuals, the estimate of effect seemed to favor a lower dose of protein. And this seems to go along with other randomized controlled trials that have found similar outcomes. One that comes to mind is the Swiss effort trial. And the Swiss effort trial looked at non-critically ill hospitalized patients, and they randomized them to aggressive nutrition support versus standard of care nutrition. And what they also found in a secondary analysis is that those who were sicker, and they define sickness as an increase in CRP level, C-reactive peptide level of more than 100. Pushing protein in them was not found, aggressive nutrition in them was not found to be helpful. In fact, there was a trend towards worse outcomes in that population. And again, it may have to go back to this increasing oxidative stress, impairing autophagy, enteral feeding intolerance that is associated with more nutrition early in the phase of critical illness.
Be sure to watch for upcoming Channel One videos on nutrition and learn more from our esteemed colleagues. Have a great day.